Patient with a chronic dyspepsia and normal abdominal ultrasound. Okay, 54 years old female.
Yep. And
Okay, these are the
so,
multiple images from the Hida scan. I can see there is a radiotest uptake within the liver, and uh, it is excreting from the biliary tract, and uh, and the gallbladder, and
mhm,
there is a focal area of increased radio tracer uptake is identified at the distal end of the CBD.
mhm.
Um, however, there is a that is causing some obstruction, and due to this, there is a delayed clearance of this radio pharmaceutical from the CBD in the gallbladder. So this focal area of the increased tracer uptake at the distal end could be a choledococele, and that is leading to the obstruction of the biliary tree. However, there is not complete obstruction as some of the tracer uptake is identified within the bowel
Okay.
loops.
So just hold your thoughts and let me take you to the next image now. So now this next image, what we did was we gave patient a fatty meal. So any fatty meal you can give them an ice cream, give them olive oil, something to, and then wait for 15-20 minutes and put them back again and take more images. So what do you see now?
Now I can see that there is a clearance of the radio tracer uptake from the CBD. However, the gallbladder is retaining the
Yep.
radio tracer uptake, and there is a relatively washout of the or of the radio tracer uptake from the liver and the biliary tract, but there is a retention in the uh, gallbladder. So
Okay.
it
So
can
let's
be
stop
due.
here and let's go back and let's talk about what do we expect to see normally. So Hida is an agent which is a hepatobiliary agent. So you inject it, and as there is a preferential hepatic uptake followed by biliary secretion, and then so in a very early, and these are what we call dynamic images. So we put the patient under the bed and then take series of 1 minute images for next 30 minutes. Now
Okay.
normally within 20 to 30 minutes you would see the uptake in the kidney, uptake in the liver, followed by some excretion into the collecting system, visualization of the gallbladder, and then passage from the biliary channel into the small bowel loops. So what you are seeing here, these curvilinear areas are the proximal small bowel loops. And so practically there is no obstruction, there is no choledococele or anything here. It's just a little bit delayed. So this is just 15 to 20 minutes, but it has excreted into the small bowel loop. And if there is an excretion into the small bowel loop within 10 minutes after injection of radiopharmaceutical, that is a normal study. Now the
Okay.
gallbladder is there. Uh, we want to see the function of the gallbladder. Okay, so what we
Okay.
do is we wait for gallbladder to fill and then give some fatty meal. So you can see the gallbladder is very much distended. And in this waiting, you can just see the bowel. There is more excretion from whatever remaining radiopharmaceutical was in the liver, and the biliary channel has excreted into the bowel loops now.
Okay.
But even after the fatty meal, the gallbladder is not contracting very well. Now, what we do after that is you draw a region of interest over the gallbladder, and then you take the early image where you have, and then the delayed image, and you see how much gallbladder has contracted. So in nuclear medicine, we also use what we call gallbladder ejection fraction. And
Okay.
normally the gallbladder should contract after a fatty meal by about 35 to 40%. And in this case, if you notice, this is coming up as somewhere around 15 to 20%, which says
Okay.
that gallbladder is not functional. is not really contracting to the fatty meal very well. And that possibly is the cause of dyspepsia. Now, that is in current days, this is probably the only reason to do the Hida scan. The other reason in today's world is when patient has a laparoscopic surgery and there is a biliary leak or a iatrogenic complication, that is another area where we can do the Hida scan. Now, in good old days, before the use of ultrasound, Hida scan was the main indication for patient who has acute cholecystitis. And the finding for acute cholecystitis used to be non-visualization of the gallbladder up to 1 hour after the start of the study. So if you don't see the gallbladder completely, but you see the excretion of the radiopharmaceutical in the small bowel loops and the bowel, but non-visualization of the gallbladder, that used to be diagnostic for acute cholecystitis, but that has become almost obsolete in last 20 years because we can make the diagnosis just by doing ultrasonic dyspepsia, where we basically look for this gallbladder function. And when we give this fatty meal to the patient, we also ask for patient whether there is a reproduction of the symptoms or not. And if it is really related with this dyspepsia is related with gallbladder dysfunction, often patient symptoms would be reproduced after that very strong fatty meal. So that is one indication. The other indication, as I said, would be any laparoscopic cholecystectomy complication in form of a biliary leak, where you can see the radiopharmaceutical tracking up in the paracolic gutters. So you would see the excretion outside the normal excretory pattern. So that's how you can diagnose biliary leak. So those are the two indication in current days. Of course, rarely if you have a choledochal cyst, another thing, you can do that. But generally, you again remember, you cannot make the diagnosis of choledochal cyst on Hida scan. You need to have that diagnosis based on ultrasound or CT, and then you can look for whether it is causing an obstruction or not. But generally, just looking at this, hold up and say this is choledochal cyst is not true. So that is just the proximal bowel loop, the proximal duodenum. Choledochal cyst, on the early images, you may see there is less uptake in that region, but gradually it will start to fill. But that also depend upon the size of the cyst. If the size of the cyst is less than a centimeter, you probably won't appreciate that photon deficient area because the resolution of the Hida scan is not that much. Or most of the nuclear medicine study, the resolution gets better only after when the size of a pathology gets bigger than a centimeter in size. So you may or may not see that photon deficient area, but classical choledochal cyst, there would be a photon deficient area and then gradual filling would be seen. And then there could be some clearance or may not be some clearance from that area. So the diagnosis in this case is basically gallbladder dysfunction. And this would be the case where ultrasound, the gallbladder would be distended. There won't be wall thickening. There may or may not be a sludge. So there won't be any features to say that patient has a chronic cholecystitis. And that is where some of the strength of nuclear medicine lies, because this is all what we call a functional study. So you get the physiological and the functional information about the organ, which sometimes we don't detect on the anatomical modalities like CT or ultrasound.
So it's already 3 o'clock. Can we take further cases? Or?
It depends on you. I am at your disposal. If you want to see more, I have no problem continuing.
Yes, sir.
If you people are tired and exhausted, we can call it a day.
Sir, these are the multi-axial sizes of the contrast and non-contrast images of the CT abdomen, in which I can see that there is increased amount of that there is a hypertense, well-defined area noted in the region of the pancreas, which is arterially enhancing, and on photovenous space. Photovenous space, it is, however, retaining the contrast somehow.
Okay, so yeah, so there is an area of
a well-defined hyper-enhancing area in the region of the body of pancreas. Likely, I will ask the history of the patient if he's suffering from any diabetes or any glucose tolerance. And then I will put it in the case of islet cell tumors, as it is well defined and it is hyper enhancing.
Yeah, so it is the functional pancreatic tumor, and which is basically a series. It comes into the series of the neuroendocrine tumor.
Now,
and this is the what in lieu of octreotide scan. So octreotide scan is done with a conventional radiopharmaceutical, so which would be either technetium or iodine or this is a PET a PET radiopharmaceutical. So gallium-68 in addition to fluorine-18, which is another most common PET radiopharmaceutical. Now gallium-68 is being used for a lot of pathology. So we use gallium-68 labeled with a PSMA for prostate cancer detection and metastasis. So this is the PET DOTA-TEC scan, AP view, MIP image, posterior MIP. Now this is challenging, and why it is challenging, because you need to know what is the normal physiological distribution of DOTA-TEC and DOTA-NOC, and you get it in the pituitary gland, in the salivary gland, in the thyroid, you get it in the liver, you get it in the spleen, you get it in the kidneys. So you get it in the urinary bladder. But this uptake that we are looking here, and on a posterior image, is the abnormal uptake. And when you fuse it with a CT, so at this time we can also do the CT scan. That's why we call it PET CT. That is the uptake of that radiopharmaceutical at that area where there was hyper enhancement on the arterial phase image, suggesting a pancreatic head neuroendocrine tumor. Yep. So that's when you use octreotide, you exactly get the same thing. We can still do the SPECT CT with octreotide. So you get that octreotide image, take a CT scan, fuse them together and label it. You would see increased uptake. But DOTA-TEC or DOTA-NOC is far more superior and far more sensitive than octreotide. So again, I'm not really sure whether these are available in Pakistan at this stage. I'm pretty much sure that wherever there are PET facilities in Shaukat Khanam or Aga Khan, they probably would be doing it. But I'm not really certain whether it's available in Pakistan or not. But remember that this is analogous to octreotide. And this is just to show the normal physiological uptake of this somatostatin receptor analogs. So you get it in the pituitary, the salivary gland, thyroid gland, liver, spleen, kidneys, bladder. And probably once you know the normal distribution, and if I put that abnormal distribution, you probably can pick it up out here. So is it clear to everyone?
I think, sir, it's more.
And I'm showing you a FDG PET study at the baseline. So this patient has increased uptake in the right side of the neck. And so the patient has a lot of palpable nodes around there. So heart uptake on FDG is normal, brain uptake on FDG is normal, excretion into the collecting system is normal, liver, low-grade uptake in the spleen. You can see the uptake in the bone marrow. You can see the uptake in the urinary bladder. So a lot of these uptake are normal. This uptake here is pathological. This possibly could be pathological. There's a small area. We need to go back and look at the CT images to work out their significance. Okay, now this patient was given chemotherapy. The patient has Hodgkin's lymphoma, and this is his post-chemotherapy scan. So somebody will jump in and tell me whether there is a good response to the treatment or there is not a good response to the treatment.
Hina, Dr. Hina, can you take up?
Yes, madam. Sir, this is a good response as there is complete resolution of the finding previously seen on the baseline image.
Yeah, good. And if we go and look at those aspects, PET CT images, so baseline and
after.
so again, remember, important thing from your perspective to remember, particularly as a radiologist, that you can have a functional resolution and you may not have anatomical complete resolution. You still can see lymph nodes anatomically, but functionally they may become metabolically inactive. So in clinical context, this is considered to be complete response. Even if the radiologically, you still tend to see some increase, nodes of increased size, but functionally they are insignificant. And that's why now patient with lymphoma, they get a mid-therapy scan. And if they show response to the treatment, they continue with the same chemotherapy. But if at a mid-cycle, after 1 or 2 cycles, if there is no response to, or there is metabolic response to the treatment, that's you change the chemotherapy earlier on rather than continuing with the same chemotherapy cycle. Okay, so and this is the same patient. So again, you can see there is a cervical lymph node out here. Anatomically, probably you still can make it out, but functionally there is complete response. And I'm going to show you another, not an octreotide, but a DOTA TOC scan. So who is going to read now? Remembering that's normal physiological distribution of DOTA-TEC that we talked about. And then this study, and this is the PET CT image of the patient.
So this is the spot images of dot. So PET and CT PET scan, and there are multiple areas of radioactive uptake they are noted, and on the PET CT images, there is increased radiotracer uptake is noted in the liver and in the mid-abdomen, and likely some nodal masses.
Well, this is the primary site. Remember, the patient has pancreatic.
Okay, sir.
Neuroendocrine tumor. So this is the head of the pancreas. So this is probably out here. You remember all these images, the most important thing, you have to look at the CT images to work out exactly where, are they in the bones? Are they in the nodes? We can't really work that part out just by looking at the PET images. What we can say, there is diffuse widespread metastasis.
Yes.
But some of these metastases could be in the bone marrow, some could be certainly in the organ, as in here, and then there a lot of them would be in the lymph nodes. So until unless you correlate, so we always have whole bodies low dose CT, and then you get images like this. You correlate and then work out where it is, where that exact pathologies are located. Now, traditionally, gallium-67 is used for 2 purposes, for infection and inflammation. So this has also almost not used very often now, but there was a time when we used it for sarcoidosis, we use it for infections, we use it for lymphoma staging. Lymphoma staging now is completely, this has become obsolete for lymphoma staging. We don't do it anymore. So often in current days, we primarily use it for the infection, in addition to some other radioisotope like the WBC scan. So now again, this case, there is a physiological uptake. And one of the problems with a lot of nuclear medicine study is to remember the physiological uptake. So low grade uptake in the liver, in the small bowel, in the bowel loops, not small bowel, small and large bowel. This is all normal. And this patient has pain in the right hip. This is the uptake in the around the right hip. Okay, so an infectious process around the right hip. Now, this is the this is what we call SPECT CT. So you do the SPECT images, and then you also combine and do a low dose CT image, and you overlap the images. So the top row is the low dose CT, the middle row is that gallium-67 image, and this is the fused image. So coronal, sagittal, and axial. And the reason I'm trying to show this case is to emphasize that if we don't have the correlative imaging, if I don't have the CT scan, my diagnosis would be very different. So what do you think, looking at the CT scan, what is the diagnosis? Where is the infection? Is it a bone infection or is it a soft tissue infection? That's anyone can answer.
Looks within the soft tissue and muscles.
It is in the muscle. Yeah, if you, especially on the axial view, you can very confidently say that the capsule, joint capsule in the bones are completely spared. And this is, so this was a myositis in a patient who had a history of drug abuse. But I would probably, if we have just done this image without a correlative imaging, we'll call it maybe osteomyelitis or septic arthritis or something on that line. I probably would not have thought about muscle to be the cause of the uptake. And that is where this nuclear medicine used to be what we call non-specific, but using this anatomical imaging combining together, it is actually much more specific because you get the functional evaluation, and in addition to that, you also get the anatomical detail. And it's important for you people to understand that, because a lot of your nuclear medicine colleague may not have that very good understanding of radiology, and they would be coming to you to help them interpret this part of the study. But actually, this part in isolation is not really that important unless you're looking at the fused images. So you have to understand also the nuclear medicine part to make the right sense of the images. If I go in a PET scan and we say, well, this is abnormal uptake. So standardized uptake is basically you put a region of interest and then you calculate in relation to something normal, which would be normal for that particular study, what is the uptake value in this here. The analogy here is the higher the standardized uptake value, most likely it is going to be malignant. But again, like anything in the life, these are not absolute rules. So people have tried to come up with some normal standardized uptake value above which something is abnormal and something is normal. It works in some instances, it doesn't work in other instances. In radiology, I call it silly, useless value. Okay, that's how I teach my trainees. It is a silly, useless value because it doesn't work 100% of the time. But basically, the analogy is the higher the SUV is, more likely it is to be malignant. But the more we are doing it, more we tend to realize that a lot of FDGs and other PET agents, they are also taken up by other inflammatory and infectious processes. So you can get an FDG positive in a CT, in a tuberculosis also now, a lot of infection. And there are some tumors where malignant tumors where SUV value can be less or normal. So it doesn't work 100% of the time, but crudely speaking, a high SU value of about more than 2.5 or 3 is considered to be significant for a malignant.
There's a question.
Do we consider WBC uptake on WBC scan in within the intestines abnormal as compared to gallium scan?
Uh, it it basically relates to the intensity of uptake and the distribution of uptake. Now that question is basically coming in relation to the inflammatory bowel disease. So there is no absolute rule around there, but if there is an asymmetry in the distribution of uptake in the bowel loop, and there's one portion of a bowel loop where there is much more intense uptake compared to the other, particularly if you are thinking about a celiac disease and you have uptake more in the region of ileocecal region, or if you're thinking of Crohn's and you have more continuous uptake in a portion of a large bowel, certainly you would consider them to be abnormal. But again, it's not, it remains non-specific. You have to go back to the clinical context and think about why we are doing that test and in what clinical context we are looking at that abnormality.
I think, thank you, sir. And another question is regarding AVN, avascular necrosis. How to differentiate between early and late phases on imaging?
So the AVN is almost, you think about it as if you are, as if we do in radiology. So on an early image, what is the change of avascular necrosis on X-ray? You get that radiolucent subchondral area, which we often struggle to find. That is the time where you are going to see a photopenic area in the femoral head or wherever the AVN is. We're talking about in context of head of the femur. But after that, when there is an osteoblastic repair in relation to the AVN, then there would be increased uptake in the femoral head. So depending on the time of onset of AVN, the pattern and uptake on a bone scan would be different. So in a very early phase, you will see a photopenic or reduced uptake in the femoral head, but on the later stages, as there is, as you see, start to see sclerotic changes and other collapse, fragmentation, then you're going to see increased uptake. So basically, it doesn't really always is parallel with the radiological uptake, but when you start to see more of a sclerotic change and flattening and deformity, that's when you start to see increased uptake on a bone scan. Before that, you see reduced uptake on a bone scan. This patient was probed. She had a history of road traffic accident remote 10, 15 years ago. And then, oh, can this be an accessory spleen or splenosis? So if that is the suspicion, what nuclear medicine test you are going to do? So we do what is called denatured RBC scan. So basically, you take the red blood cell, you denature them, you level with an isotope, and then you re-inject them. And that is taken up by the reticuloendothelial system. So reticuloendothelial system, liver, which is normal, and this area of uptake showing that this was an accessory spleen. In that. So that is the only indication for denatured red blood cell scan these days, to look for splenicules or accessory spleen. And it becomes important sometime when you have a patient with metastatic disease where you're suspecting metastasis and you have small nodules in the peritoneum and you don't know whether you're looking at a peritoneal seedings, and especially when the patient doesn't have a spleen or patient has a previous splenectomy. So in that setting, that becomes important. So denatured GI bleed scintigraphy, which is basically you inject a radio level blood intravenously and you take the image of the abdomen and pelvis. And primarily, again, you need to remember about the physiological distribution of that radio-labeled red blood cell, which would be liver, spleen, the background in the abdominal aorta, arteries, veins, kidneys. And then you would see the excretion into the bladder. Now, anything extra would be abnormal. So in this case, if you can, you make it out in the very early images, you start to see some extravasation of this radio-labeled red blood cell in the right upper quadrant in here, and that gradually increases with time. With time, it increases, and then sometime, depending upon where it is located, you can see it starts to fade, and it may start to move either in an antigrade or retrograde direction. Okay, that is a site of bleed. So that is a GI bleed, and it's important to. The most important thing that we need to understand is where is the site. So where do you see the first blush? Because that would be the site of the bleed. And that becomes important if you are going to go and embolize that, because you need to know whether it is in the distribution of which arterial territory, because that's where you are going to get that flush. So identifying in here, probably in the proximal ascending colon is where it is. So it gives you also, if you have to intervene and you have to embolize, where you embolize. So this is another patient, and once you have seen that previous case, can we identify where is if there is a bleed, and what is the initial site of the bleed? Anyone?
Dr. Huran, can you please tell?
Sir, it is at the level of the, sir, I don't know, either the celiac trunk or superior mesenteric artery.
Yeah, so, and this could be tricky, isn't it? Like it is in the transverse colon. So
yes, in the colon.
And you cannot be very, very certain. I mean, it's starting in the very more proximal portion of the transverse colon. So yeah, it could be either. And that is a real life problem. Sometimes you probably can, if you track it up, this gives you a very good example of an antigrade move towards the transverse colon and then getting more down later on into the descending colon. So these would be image studies. I personally feel it is much still better than the contrast enhanced CT or CT angiogram that we do, because the advantage with this is most of these bleeds are intermittent. When we do the CT, we only capture just that particular second where if patient is bleeding at that time and we capture out the flush, then it is very good to identify, but if patient is not bleeding at that particular time when you have taken the images, we may miss it out. With this, we can do the images for half an hour, 1 hour. We can repeat the images if the patient has a repeat of rectal bleed in the next 24 hours without giving any more radioisotope, and bring back and take more images. Okay, a child with abdominal pain and melena. And this is another bleed study. Bit of a different radiopharmaceutical. Here we don't label the red blood. We just inject technetium pertechnetate here. So the radioisotope that we are giving is just technetium pertechnetate, which is excreted in the liver, in the thyroid, but also in the stomach. And the abnormality is out here. So who is going to tell what is this?
Diverticulum.
This is Meckel's diverticulum. What you need to remember is that Meckel's diverticulum, if it is Meckel's diverticulum, it should be seen at the same time when you see the stomach. If it is coming later, then it is not Meckel's diverticulum.
Okay.
So the key, the diagnosis is the visualization of this abnormal accumulation of radiopharmaceuticals should coincide with the uptake in the stomach. It should parallel that. It may not parallel in intensity, it should parallel in its initial visualization. And that the lower one that is coming on later on is the urinary bladder. And you can make it out, you can't call this to be, if there was no uptake of here, this could not be the Meckel's because it is not paralleling the stomach. So, and that is primarily because of the presence of the ectopic gastric mucosa in the Meckel's diverticulum. So that's the thing to remember. This is a patient who has a large hepatic mass, normal enzymes, normal tumor markers, middle-aged male, and this is the lesion in the liver. And this was a part of the triple phase CT scan. We were not sure what exactly it is. What nuclear medicine study can be used to further characterize this? So when you do sulfur colloid, what you are suspecting then? What are you suspecting this lesion to be?
So probably an FNH?
Okay. Statistically speaking, an incidentally diagnosed hepatic mass, which is more likely, an hemangioma or an FNH or hepatic adenoma?
Sir, hemangioma and adenoma.
Probably in between hemangioma and adenoma, which is more likely now that this is a male patient.
It's a male patient, so chances of being hemangioma is great. Adenomas are more common in females.
So hemangiomas. And if it is a hemangioma, then what study you are going to do? What nuclear medicine study would be confirmatory?
RBC labeled scan.
RBC labeled scan. So I can show you now the RBC labeled scan. So again, we do it in different ways. So the top images are the perfusion scan, just few second scans apart from each other. Then you have these, what we call a little bit delayed scan after 2 to 3 minutes and the scan after 2 to 3 hours. So this pattern on, and then this pattern on delayed scan.
This is typical of hemangioma.
Remember, if everybody remembers the typical enhancement pattern of hemangioma on triple phase CT.
Peripheral puddling, nodular
peripheral puddling, discontinuous, gradual central filling.
Yes.
So until and unless you have this very typical enhancement pattern where you think about FNH, then you can certainly do colloid scan. But being hemangioma being the most common benign hepatic tumor, probably the likelihood of hemangioma with heterogeneous enhancement is much more likely. So then you do RBC scan, which is basically you label the radiopharmaceutical and then you take images. And this is most sensitive and most specific, but you only need to do it when you cannot make the diagnosis on the conventional imaging. Staging and restaging of the prostate cancer. And this is called gallium-68 PSMA, prostate specific membrane antigen scan, which is again a PET scan. Like any PET scan, there is some physiological uptake. So in this case, all the salivary glands uptake, lacrimal gland uptake is physiological, and so is the uptake in the liver, spleen, bowel loops. There's also physiological uptake in both kidneys. In this case, we see only the left kidney uptake, and of course, the bladder would be physiologically present too. So there is, hopefully everybody can see there are some areas of uptake in the mediastinum or chest. Again, we don't know it's mediastinum or they are chest. You need to go and look at the CT to work that out. And this is the correlative fused images. So that is the primary site. There is this uptake is, you can very well make it out. This is in the bone, so posterior acetabulum. There's an uptake on the right side, which correlates here. So metastatic lymphadenopathy. And then probably we all can work out why the right kidney was not seen, because this is causing obstruction, and probably the renal function was impaired because of the obstruction of the distal right ureter. So this is how the normal PSMA scan would look like. So physiological uptake in all the salivary glands, lacrimal gland, liver, spleen, kidneys, bowel loop, urinary bladder, and then the abnormal uptake. So with all these studies, it's very important to have a very good understanding of these normal physiological distribution. And physiological distribution of all these radiopharmaceutical, they are not exactly the same. There is a bit of a variation here and there. This is a patient who has dysphagia, who has some sweat. There is a palpable left cervical lymph node on clinical examination. And this is a FDG PET CT scan. So this is the fused image here. This is the MIP image, and this is just the PET image. I always love to look at these fused image because that's where most of the meat is. So you can see there is a palpable, that's probably the palpable lymph node, but there is also uptake on the contralateral side in here. If you look at the MIP images, you probably can see the spleen to be a little bit enlarged. There is also more focus of uptake both above the diaphragm and then possibly some below the diaphragm too. We go down and you look at the other sides. There is a bit of an asymmetry in the pharynx. There is slightly more uptake on the right than on the left. There should be normal uptake in the pharyngeal mucosa too, but asymmetry is always a little bit concerning. But the asymmetry is on the right side. The palpable node was on the left side. So something to keep in mind. We go down and look at the abdomen. We see the spleen to be enlarged. There is some low-grade uptake, which can be physiological too, but size is certainly looks enlarged. And there is also a lymph node around here, which has a low. And this would be where we'll call low SUV value, because this is a low SUV value, but there's an uptake below the diaphragm. So what could be a couple of differential diagnoses with that history of dysphagia, night sweats? What was the history? Dysphagia, night sweats, palpable left cervical node, and the findings that we are looking at. What would the 2 or 3 things that you would like to consider?
Non-Hodgkin's lymphoma.
It could be non-Hodgkin's lymphoma. That's what it was actually. If it was, this asymmetry was on the same side where I had the palpable node, I would be worried about the nasopharyngeal carcinoma too. But given that it was on a contralateral side, though there were some nodes on the right side, but these nodes were not palpable. So, statistically speaking, they probably would be not related with this one. But again, you do the clinical examination, you do the, you would work it out, but eventually on biopsy of that left-sided lymph node, it was a lymphoma. So bilateral thigh and right groin pain in a middle-aged female patient, and I'm showing you a conventional old bone scan, which is basically, we haven't done the whole body for this because patient came up with thigh pain. So in Australia, we don't do the whole body. If we are not looking for metastasis, we are looking for a local cause for a pain. So who is going to tell me what is the diagnosis? This is the uptake, abnormal uptake in the lateral aspect of bilateral mid-femoral shaft.
Dr. Huran Tariq, would you please take up this case?
Yes, ma'am. Sir, these are bilateral symmetrical areas of the radiocircular uptake in the mid shaft of the femur bones.
Mm-hmm. Okay,
so you can
well say I don't know the diagnosis. which is fine.
Yes, I don't know the diagnosis.
Okay, if I show you the X-ray, the CT scan of this patient, that is going to help you, I can point you, that's the only abnormality that you see where you saw that uptake.
These are within the cortices, sparing the medulla.
Within the cortices. If I have not given you one history of the patient, but which I have hold it which is unfair, but this patient is being treated for osteoporosis.
Yes, sir. These can be looser zones.
Yeah, so these are that anti-osteoporotic induced insufficiency fractures. They classically occurs in the proximal shaft of the femur after the patient has taken those medications for about 4 to 5 years. So, and then they tend to. So there's a very classical appearance. The only thing that you're going to see on a CT scan or on X-ray or a CT scan would be a very subtle cortical thickening or irregularity. So something we are getting more and more aware of as this treatment is getting more popular, and so. But these are not seen in early stages. It takes 4 to 5 years of continuous treatment. So one of the complications of osteoporosis.